Welcome to the Menowave Lounge, where today we continue with our fascinating conversation with Dr. Dovile Kalvinskaite. Recently, in our menopause support group on Facebook, Dr. Dovile went in and introduced herself as an OBGYN and simply asked, "What questions do you have for me?" Within an hour, she was flooded with hundreds of questions and comments, and so today she's going to spend some time answering them for you, as well as she'll be sharing important tips on how to talk to your doctor about menopause and how to advocate for yourself. Stay tuned for part 3 of our conversation with Dr. Dovile in the Menowave Lounge, Hot Flashes and Cool Conversations. Welcome to the Menowave Lounge, Hot Flashes and Cool Conversations. I am your host, Marti Daly. My co-host, Robin Duke, is out today, but I'm so excited to wrap up this 3-part series we had with our own Menowave care provider, Dr. Dovile Kalvinskaite. If you have missed us, this is the 3rd part of a 3-part interview series. Just to refresh your memory, Dr. Dovile works in the UK as an obstetrician gynecologist, menopause specialist, and certified lifestyle medicine physician. She is also a certified high-performance coach. She offers holistic care, blending medical expertise with coaching to support women, especially through menopause challenges. In episode 22, we spoke with Dr. Dovile about the truth about hormone replacement therapy, the misconceptions about it, and the risks and benefits of taking it. Last week in episode 23, we shifted gears a little bit to talk about another important key in feeling your best during menopause, lifestyle medicine. And today we're going to finish our conversation with Dr. Dovile, who will share important tips on how to talk to your doctor about menopause and how to advocate yourself. So welcome back, Dr. Dovile. I'm so happy for you to take time and finish out this series. It's been so informative. I know I have learned so much, and so have our women as they're listening. I'm getting comments that they're enjoying it and they're thanking us. So thank you. Just jumping right on in, as you know, as you've seen in the group, a lot of women are struggling with what to ask their doctor, how to approach their doctors. And as you have informed us, and as you well know, not every doctor is educated the same. May I ask, if you don't mind sharing with us, what do they come to you with? What are some of their concerns? And do you have any tips or advice for these women on how they can make the most out of that short time that they get to spend and that they can get their concerns addressed?
No, absolutely. Well, first of all, thank you again for having me here and giving me space to share this information. I'm not sure exactly how it works in the US, but in the UK, they first get to their GP, so they're like a family doctor, to discuss this, and they can start the HRT there. So usually the GP, so their general practitioner, will send at least they're supposed to send the complicated cases where, it's not sure whether HRT is the best option or HRT is not possible for one or other reasons, to discuss other options, or if it's difficult to find the right combination of HRT. And then they send it to us to adjust that. Unfortunately, what I see very often, probably I'd say at least 50%, if not more, of the women that are referred to me is usually they didn't get any help with the GP or in that first line or from nurse specialist, purely saying, oh, maybe you're too young to be menopausal, or you still have your periods, or you don't get hot flashes, or HRT is too risky in your case. Various reasons why they were not started on HRT, or GP just didn't like it, or you said, it's not a reason to not start HRT. So unfortunately, I thought about that a lot, like how to improve that. And I think I'm very grateful that we are having this conversation, first of all, like how to advocate for yourself. I probably would be very generous saying that 90% of doctors, only 90% don't know how to deal with menopause, but I would be very generous. Probably it's more towards 99%. Only the ones that actually make the effort to learn. And like we mentioned in a previous podcast, in med school, we probably get an hour, if that, teaching on menopause, and in obs and gynae training is another couple of hours. And only if you make an effort to learn that yourself, you don't really know what's happening and what to expect. And you know about hot flashes, but you don't know that there's probably 70 plus other different symptoms, and an HRT is effective like 96% of the time. And we discussed lifestyle changes can be enough, but understanding the whole approach is very important. So how to speak to that doctor? First of all, only probably some studies say 50% of women seek help in the first place. And as we mentioned before, about 86% experience some sort of symptoms, and about 40% of them experience severe life-altering symptoms. And if we say, only 20 to 50% of them seek help in the first place, that's scary. That's really scary and sad, like how many women are just, suffering in silence. What's more saddening, that out of those who approach their doctor or care provider, only maybe a third get some sort of help. And with regards to HRT prescribing, in the US, I think it's about 4% of women are prescribed HRT.
Only 4%.
4%. In the UK, in some areas is like 14%, but in some it's about 2%.
Oh my goodness.
It also depends on the area and access to healthcare in the first place. So imagine that 86% experience some symptoms, 20% to 50% only, seek help. And of those, only like 4 to maybe 14% like get the HRT. And I'm not saying that everyone should be on HRT. It's not for everyone, and there are other things we can do, but it just gives you the perspective.
Absolutely. I had no idea. I mean, 14% from some parts of the UK compared to the 4% in the US. Still, it's like, that's still not a whole lot. That's still very, very low. My goodness, I had no idea. That is really shocking, especially.
Yeah, and almost half of them, what they're told? It's your new normal. It's just learn to live with it.
Oh, that stinks. That's so disheartening. May I ask really very briefly, why is it that so many doctors, I mean, I know you took a special interest in it from the very beginning, but why is it that so many doctors don't take the steps that you did and go for that particular specialty?
Well, it's a difficult one to answer. I mean, first of all, menopause is like, not even, among the society, that group of women is like, you reach your 50 and you're done, almost to that. But it's just lack of education, lack of understanding how important that is, how many areas of life and health included it affects. And I'm really glad that menopause is becoming, a hot topic more and more, and on, big media and social media. And it will take a few more years, but it will become the norm. But we're still in that sort of dark ages. So hopefully Renaissance is coming, but just lack of education and understanding. And then, doctors are busy with their special interest. And then it was like really funny so I did a post on social media like a couple of days ago about frozen shoulder. So frozen shoulder is like in med books, it's described, it increases between ages 40 and 60, particularly for women. Peak is about age 55, and the cause is unknown. And then you think about it like, women between ages of 40 to 60, peak at 55, cause unknown. What could that be?
Could it have anything to do with our thinning tissues and our
menopause? Estrogen. It just like requires you to sit there for a minute and just like, seriously. So lack of understanding or lack of research for women in that group. Like we mentioned before, there's so many studies done for pregnancy, fertility, improving those outcomes, and just probably 0.03% of all the money that goes into research for women is for menopause. Like it's, what are we talking about? We don't even know what we're talking about, basically.
Right. So is it true? I think I've seen that more money goes into and more attention is focused on like erectile dysfunction.
If men were experiencing this amount of problems, it would be done and dealt with a long time ago.
Exactly.
The other argument, menopause is natural. Why are you trying to fix it? Why are you trying to medicalize it? Erectile dysfunction is natural, right? Heart disease, breaking a bone, like it's natural. Like, why don't we leave those things, or hip replacement? It's natural. The hip is worn off, like sit in your bed and die off. Like, why don't we say that to those people? And I'm sort of exaggerating, but menopause is the same. Yes, it's natural, but does it mean that women have to suffer?
Right.
No.
Right. And every woman is going to go through it at some point. And some women even feel guilty for asking for HRT. Like, am I going against nature? Like, no, you don't have to necessarily go to have HRT. No, it's not for everyone. It's
It's actually safe for most of them, but you don't have to if you don't want to. But there's so many other things, and understanding the risks and how it affects your long-term health, and how to mitigate those risks with lifestyle changes, and understanding pros and cons for HRT for yourself. It's important to have that conversation. Even if you're not going to go for HRT, it's still worth going to see your doctor, discuss the risks for yourself, your personalized risks. And maybe there's a personalized care plan. Maybe you need some sort of follow-up. Maybe you have increased risk for heart disease. And we have to learn to be advocates for ourselves, and go and have that conversation regardless. And I think today's topic, how to speak to the doctor, I think would be a good one for everyone to listen to.
Well, exactly. And so just kind of going into that, so like you said, was it 90% of doctors don't really even know much about it at all. And so we're going into our OBGYN and we're saying, okay, here's how I'm feeling. And I'll say this because I have a friend that she had gone in and she was told, well, because your periods are regular, you're not in perimenopause. You don't have to worry about it. We'll give you an antidepressant. Bye-bye. Is that it? Is that it? Is that all?
That's painful to hear. And knowing that at least, 66% women are unnecessarily prescribed antidepressants is just heartbreaking.
What could she have done differently, or what should she do now?
So first of all, just before going to speak about what to do in the office, first of all, don't wait. And even if you have what you said, regular or periods, if you start experiencing symptoms in perimenopause, and we spoke like it can start 5 to 7 years, 10 years before going into menopause. So it can start even in your late 30s. So just to briefly mention, worsening PMS, periods getting either shorter or longer, less regular, the hot flashes, poor sleep, the mood changes. And we know that for mood changes, HRT is actually first line gold standard treatment. It's not antidepressants. Antidepressants do nothing for menopause related mood changes, like literally nothing. And also they affect your bone density long term, like in a bad way. Wow. So it's not something you want to be on if you don't have to be. And they have their place. Like, I'm not saying, everyone now has to stop it, but
right.
But it's just, we have to be careful. So understanding those things and knowing that information helps you advocate. So step number 1 would be, don't wait and do your own research. So listening to podcasts like this, or following experts, or reading a bit about it, getting familiar with the national guidelines that are available to everyone. So for example, in the US, there's North American Menopause Society. In the UK, there's British Menopause Society, NICE, which produces guidelines. So there's various places where you could read up a bit, or even print off and mark the places that are relevant to you, so you are prepared. And if someone says, oh, you don't have hot flashes, so I cannot give you HRT, actually, there's other reasons why HRT can be given. It's not just hot flashes or lack of periods. So do your research. The other big thing is tracking your symptoms for some time. So especially in perimenopause, so some of those symptoms might not be very specific. They might be very cyclical, like the worsening PMS, the hot flashes just sometimes, not every night, or the mood-related changes, the sleep. They're just like tracking symptoms. And most of those appointments are 10 minutes. Yeah. You have to be precise and concise. And what I would say, when you come in, you just say, I'm 99% sure this is perimenopause or menopause because of these reasons, this and this and this. I track my symptoms. You can even bring an app or written it down somewhere that, these are my symptoms. That's why I think this is perimenopause or menopause. You can even show the guideline, the symptoms. I have done my research, and the doctor will take you seriously and a bit differently. Like, they know you've done your work. They cannot just dismiss you. They have to have the proper conversation. And the other thing, like, if you think that you will want to discuss the HRT, is just learn about those HRT options. Again, is just going through the guidelines or reading up, like estrogen, progesterone, the patches, the gel. Just have your preferences. The doctor might not agree, or might say, actually, this is better, or this is not right for you. But at least you know what you're talking about, and you don't have to waste that precious time just learning what are the options in the first place. So thinking about, you don't have enough time, or you have little time, so use that time wisely. I think that would be sort of step 1, the preparation and being your own expert, reading up before even going to tracking your symptoms, understanding the HRT and what you want, so you arrive prepared. Then preparing questions is very good in advance. The brain fog, memory lapses.
Oh, yeah.
Those are the real things in perimenopause and menopause. And I had so many patients come in and it's like sitting there and was like, oh, I forgot what I wanted to ask. Like, oh my God. And then you have the ones that come with like a list of questions. And even though that sometimes sounds scary, but actually you just save your time. Like, oh, I went through this. Okay, you answered this. I've done that. So you are prepared for that with your questions. And for me, actually, when I was a bit younger, less experienced, that would, oh my God, the list of questions, like this woman is like crazy. And now I'm so grateful that they come prepared. I know they're serious about this and we have like educated conversation. I had one patient, she was a teacher. She brought like a huge graph of her symptoms, marked like each month, every day, different colors.
Oh, good for her.
I mean, not necessarily everyone has to do that. But
and not all of us are visual data points.
No. But just track the way it's convenient for you. So prepare the questions. And if you think that 10 minutes is not going to be enough, just request an appointment like double slot time. And in the morning when doctor is not tired and has a bit more patience. Other thing, bring support, a friend, a partner. Sometimes if you get into that space of overwhelmed anxiety, which is another big thing of perimenopause, menopause, the anxiety and the brain fog, like we mentioned, if you have someone to advocate or ask those questions for yourself or remember what was said. I really like when women come with their partners, we're having that conversation and then partner understand what she's going through and can see it, from different perspective. Unfortunately, it doesn't happen very often, but I really like that.
Yeah.
And when we discuss lifestyle, we can discuss with partner as well. Like you both can do this, like you can support each other. I really love that. So just bring support and it just going to make a huge difference. Yeah. So that's kind of preparation part. So prepare, like very simply speaking, do your homework, prepare, track your symptoms, get your questions ready. And then when you get to the doctor, you just say, I'm sure this is what we're dealing with and this is what I want. Like be very clear and concise. Obviously, if it's a doctor that you're seeing first time, have a list of your medications if you're on any, your medical conditions, your family history, so we don't have to waste more time there. So you're like very clear, these are my risks, this is my medical background, these are my medications, this is what I want, what do you think? I mean, be ready to explain. If doctor is not that educated and doesn't understand that frozen shoulder is part of the menopause, be ready to explain and and don't feel like because it's a doctor, you have to keep silent or just answer the questions. And what else? Discuss openly the reasons why you want to be on HRT, your reasons. And some doctors, they will have their own opinion, which they're entitled to that. That's fine. But be clear why you want this, why you think it's important to you. And if it's a good doctor, they won't get offended to be educated a bit. Like sometimes people come and tell me the most interesting things, what they tried, what worked for them. And I really love to hear those and use it later for others. So if it's a good doctor, they will listen. Yeah. Understand your rights and options. And it's your right to be part of the decision making, especially if met with resistance. It has to be a joint decision, not just, doctor saying, oh, just deal with it, or I don't prescribe HRT. You shouldn't take that. Regarding your decision as unwise is not enough a reason for them to refuse. For example, women who had family history of breast cancer in their family. It's not a contraindication to prescribe HRT. It's not. Yes, you might have increased risk of breast cancer in general because of your family history, but HRT will not add to that risk.
Right. Any
more than to anyone else. Some doctors might say, oh, it's unwise, you had this family. And actually, that is one of the common reasons why they're sent to me GP didn't prescribe because of the family history. And they had to wait like a year to see me for me to say, no, that's like nonsense. And then that's, delayed care on their part when they could have been started like ages ago. They're thinking that you're unwise is not enough reason to refuse. And you can show that you're informed and have considered the consequences of your choice. If you understand all that, it's like with any other medication. Every medication has side effects and risks and benefits. Right. But somehow when it comes to HRT, the doctor has to have their own preference and decision based on that. How does that make sense?
Exactly. It doesn't at all. At one time I thought well, maybe is it a male versus a female physician? But what I'm seeing with the comments in the group is that sometimes they're getting even more pushback from a female practitioner than a male, which is nothing about nothing, but it's an interesting dynamic there. Like, what is this
Yeah,
about?
but it can be both ways. Like sometimes I hear actually about male practitioners not prescribing, and particularly not prescribing vaginal estrogen.
Oh,
I don't understand. But it's like, seriously, you don't have the vagina. You don't even have to have an opinion about vaginal estrogen,
exactly.
which is safe for everyone. So it's just a bit annoying. And I mean, if after discussion, the doctor does, or the practitioner does not consider that HRT is a choice, doesn't feel like it's an appropriate course of action, they don't have to provide it, but they have to explain the reasons for refusing to do so and include other options, and including your right to seek a second opinion. And if you disagree, you say so. Now, challenging denials, obviously that's always tricky. It's your doctor, it's an authority, but advocating for yourself and the reasons that you should never take for as a reason why the HRT wasn't prescribed is no, you're too young to be menopausal. Those kind of things, like it's too risky. What risks are you talking about exactly? Like the main things why HRT shouldn't prescribed really, it's if you had a breast cancer in the past yourself, if you have bleeding that's unexplained and needs to be investigated, very complicated medical conditions that sometimes require a specialist, to speak to, that's fine. But you're too young, or this is just part of your life, is not a reason. And you still getting your periods again is, yeah, you're in perimenopause and you can be in that for like we said 10 years, and the ideal time to start the HRT is actually in the perimenopause and first 10 years of menopause. That's the most health benefits long term. So actually I'm still having periods, maybe it's a good thing, like I'm starting it at the right time if I need to.
Right.
And like, you don't have to start the HRT, but at least you should have that conversation to understand what are my personalized risks and benefits of having or not having HRT. Let's say someone who had, family history of osteoporosis, breaking bones, the heart disease. Maybe it's actually, for me, it's worth considering the HRT to prevent those risks because I'm at very high risk. And we discuss how HRT is effective for reducing heart disease by 30%, diabetes again about 30%, like overall mortality, if reducing the risk for that. Like, it just, is it good for me? Is there any other ways I could deal with that and reduce risk? Maybe at the end of the conversation you will think, oh, actually the risks for me, like personally me, based on all the other things, is too high, but now I know, so I'm now empowered to do other things. But I know we had this conversation, so just having that conversation is important. And if your doctor just offers you antidepressants, if it's mostly mood symptoms, menopause guidelines are very clear that antidepressants should not be given as first line for low mood associated with menopause, because there's no evidence they help. Like,
Right.
if it's purely menopause, and women say to me, actually, who had a history of anxiety or depression in the past, and when they come to see me and they say, I have this anxiety, this low mood depression, but it's nothing like it was. Like, it feels physical, like it just feels different. I know it's menopause related. Antidepressants is not going to help with that.
Right.
It's not. So just dumping some antidepressants on that, it's not appropriate. And you should say that.
I was thinking back as you were saying that, one of my doctors told me the same thing a couple of years ago. It's the same thing. And I was 48. But yeah, would you like to try an antidepressant? And I was explaining, now that I know with my libido changes and the crying and the emotions, and I'm not an anxious person, I was thinking, well, no, I don't really think that that's what I need. I'll deal with the emotional side on my own because I have the tools. But now after talking to you, it's even more affirmation or reinforcement of like, no, I should, I could have dug deeper. And now that I know, and I will. Wonderful.
Yeah. So sometimes the doctor might say, oh, I have to refer you to a specialist or someone else.
Yeah.
And it shouldn't be necessary unless there's a complicated medical background situation. And like I mentioned, family history of something, of anything, is not a contraindication to not take HRT. That's one thing. Other thing, sometimes about the vaginal estrogen, sometimes they say, oh, you're on the HRT, then we will not give you the vaginal estrogen. Again, that's nonsense. It can safely be done together and probably should be done. The vaginal estrogen is not absorbed in any significant amount systemically, so it doesn't add any additional risks. but it adds a lot of benefits with regards to vaginal symptoms and bladder symptoms, and even reducing risk of UTIs and all that. So always worth mentioning the vaginal estrogen as well, because many doctors will not even suggest you that. So again, just knowing your symptoms and what's affecting you, you will bring that up even if they don't ask. Again, more than 80% women will have the GSM, what is genitourinary symptoms of menopause. So it's definitely always worth discussing. And the earlier you start, like we discussed in the previous episodes, the better long-term outcomes as well. Reducing the risk of shrunken vagina, how my patients call it. Yeah.
Oh, shrunken.
Yeah. And then obviously, don't feel rushed into making decision. That's another thing. Like if you're not sure, if you need time to think, book another appointment. Don't feel rushed into taking antidepressants or taking HRT or not taking. If you're not sure, if you just like get overwhelmed, just say, I just need to think about it. And then obviously persist if necessary, get second opinion, get another doctor, consider, new healthcare provider. Consider there's lots of now online telemed services that you can get, particularly for menopause. I think there's 3 different things in the US. Online telemedicine that I think one or 2 of them are covered by insurance. There's different ways you can approach this. And I think North American Menopause Society has lists of care providers that you can look based on your postcode. So just look for someone who's educated if you don't get help with your regular healthcare provider. Yeah, menopause is natural, but you shouldn't put up with the symptoms if you don't want to. And having that conversation as early as possible is the key. Probably 1/3 of women have to see their care provider 3 or more times before they get HRT prescribed. So that's why I say, don't wait. It might take some time.
Oh my goodness. That's a good one to know, especially for those of us who it can take a good long time to get in to see someone. So get on it now, essentially.
Yeah, exactly.
Wonderful. All right. So very quickly in the time that we have left, we'll get through as many of these as Dr. Dovile has time for. Is a slightly elevated HCG level common for menopause?
Simple answer, no. So HCG has nothing to do with menopause. First of all, was it like a pregnancy test? It can be related to certain tumors or other conditions that it just needs, if it's really elevated, it has to be checked out. It has nothing to do with menopause. So definitely to your healthcare provider and investigate that further.
Yeah, interesting to think that if someone went so far as to test their HCG level and know that it was off, that there may be something going on. Good to know. Could an autoimmune disease in menopausal women be caused by a decline in progesterone?
So we know that both progesterone and estrogen are involved in immune system regulation, immunomodulation, and all of that. And we also know that women are more likely to get autoimmune conditions, and that peaks around the menopause age. So obviously, like with everything in menopause, there's lack of evidence, lack of research. Basically, we don't know, but I think it's very safe to assume that because we know these hormones are involved in immune system regulation, and we lose them, and then we see more of these autoimmune conditions. Yes, particularly progesterone. I think there's more evidence for estrogen, but progesterone is also involved in that system. So I think it's a combination of things that happen. And estrogen, we know, is anti-inflammatory. So we're losing estrogen, there's more inflammation in the body. So that is one of the reasons we have more allergies and more of these things. But progesterone as well, and it's just, unfortunately, there's not enough research, but I would say there is some sort of involvement, definitely.
That's interesting. Can the onset of menopause cause a sudden start or increase in food reactions, GI exhaustion, mouth ulcers, tongue flare? Because, and she asked, because some of these same symptoms go along with other serious diseases and it's scaring her to death.
So what we now just discussed, the more of allergies. Yes, we know that in menopause you have more allergies, the burning mouth, the burning tongue. These things definitely can be related to menopause, but like with everything, if you have these weird symptoms we would always investigate other things. Like we would check your autoimmune panel in the blood work if it's not clear, your thyroid function, your even vitamin D levels and other things that's happening in your body. And if we rule out everything else, then it's safe to say, it's menopause. And if nothing's helping, maybe HRT probably will.
That's a very important thought, because we talked about before of all these different symptoms get siloed into whole different areas of treatment. And yes, so these things, like you're saying, is okay, well, let's rule out all these other things. But rather than saying, well, if we can't find anything else, oh, don't know what this is. Okay, could it be menopause? And let's try this. It's like a very important key after you've ruled out everything else.
Yeah, not to put in medical books like, oh, the cause is unknown. Like
right now, okay, she's 51, her tongue's burning, other things are going on.
Yeah, or it's all in her head. Like, it's like very common among doctors. Like, oh, it's just like all in her head. Like,
I know. And then they go into the group and there's like 50 women saying, my tongue is on fire. What the heck is this? I get that. Will our lifespan be affected by the constant attack from menopause symptoms?
It's a tricky question to answer. So menopause symptoms itself, they will not shorten your lifespan. Unless, when we're talking about mental health issues, and the suicidal thoughts are 8 times more likely to happen for menopause women. And we know that self-harm increases around that age as well. So if we're talking those things, we could say, but hot flashes, it's not going to kill you. However, the menopause itself and the implications for long-term health, if we're not doing anything, definitely can affect your lifespan. And like we said with the HRT, HRT reduces risk of all-cause mortality, meaning that if you're taking HRT and getting those hormones back, you are less likely to die from everything, basically, breast cancer included. For example, your symptoms can be a sign of bigger problems. What I mean by that is, like, if you're having very severe hot flashes, basically what hot flashes are, what we call vasomotor symptoms. So your blood vessels regulating to that, well, lack of regulation, and with the lack of estrogen in the vasoconstriction, so the vessels dilating or constricting. What that shows, if you have very severe hot flashes, that means your vascular system is very sensitive to estrogen, and very likely you have a lot higher risk for heart disease later in life. And those changes have already started in your vessels. That's going to cause the heart disease or vascular disease. So it can be a sign of something else. Bone density, another thing with menopause. So your bones, if you're not taking HRT, if you're not exercising, not doing resistance training, not getting enough protein, you might get a fracture, osteoporotic fracture, like, hip fracture. 50% of those are preventable. And like we mentioned before, the ones that get a hip fracture, the 70% of them might die within the first year if nothing's done. So does the menopause symptom cause the early death? No, not directly, but indirectly, yes, if you're not doing anything about it. So it's not a straightforward answer.
Right. But I really like the answer, because you're right. They can feel like there's something wrong. They feel like that they're going to kill themselves, and from the stress or the heart palpitation or what have you. And like what you're saying is, then in of itself, no, but we could almost look at them like, okay, here's a little warning flag going up. Like, okay, well, let's take a look at what this could also be. And I think that's a very good distinction, but a very important one, is we can look at these like, okay, we're not falling apart, but it's like our body's sending us messages of, okay, well, let's go and look at what else. This is something we need to take care of.
Yeah. And for example, with severe hot flashes, even if you're not taking HRT, knowing that you're more likely to have heart disease, or you have higher risk to develop those later in life, you can do other lifestyle change, and you should do other lifestyle change, even if you're taking HRT. You're just aware of that and you're more mindful. So understanding that is just very important. And that's why, having that conversation early with your doctor, or with someone who is educated in that and can point out those things for you and help you create your personalized plan, starting with lifestyle always. Even in my clinic, like I always say, we can discuss HRT, but like if we're not discussing lifestyle, I'm not prescribing anything. Like we have to start with the lifestyle changes.
Oh, I love that. I absolutely love that. How do you know if you're in menopause when you've had a partial hysterectomy or a full hysterectomy?
So we would go by symptoms, first of all, and other way is to do a blood test. And we would do a blood test to check the FSH, LH levels 6 to 8 weeks apart. So 2 blood tests to confirm. So obviously, if they're in perimenopause, those hormones fluctuate. So there's no real way to tell. But if full menopause, then the blood test will say. But we would go by symptoms. If let's say we want to start HRT, we don't have to have the blood test to confirm. Having the symptoms and ruling out every other causes is enough.
Will regulating my hormones help my diabetes or blood sugar levels?
100% yes. Like I mentioned, so estrogen is a lot involved in the insulin pathways, the glucose metabolism, and we know that women in menopause who are not on HRT, they're a lot more likely to develop diabetes. So obviously lifestyle and nutrition and physical activity and keeping the lean muscle mass. So the more muscle you have, the better your glucose metabolism is. So lifestyle, again, number one, but the HRT definitely helps with that. So yes, not having those hormones increases the risk of diabetes and all those things. Again, understanding your personal risks and addressing that is important.
Wonderful. Just a couple more. I read that the lack of hormones is a risk factor for dementia, namely Alzheimer's.
Number one thing that we say, lack of research, but we know more and more about it as we go. And what we know that women are more likely to develop dementia. That's number one. And we know that estrogen plays a huge role in brain function and glucose metabolism. So imagine, and estrogen is like an engine for a car. And so glucose would be the fuel, but the estrogen is the engine, and you lose that engine. And we know that if you start the HRT very early, you reduce the risk of dementia. However, it's that window where we start is very important, becomes very important, because if you start HRT a lot later, so more than 10 years after menopause or even longer, it either doesn't affect the risk of dementia, or there was even a study to show that dementia develops quicker. So that window when we start HRT is very important. Again, going back to the point, don't wait, discuss this as early as possible. And if you want to start HRT, start as early as possible. Estrogen plays into the metabolism of glucose, and that starts to change around age 40. So our brain becomes more resistant to glucose, and that metabolism becomes affected. So that's why our mind slows down, the memory lapses, the brain fog, because of how estrogen and lack of estrogen affects the glucose metabolism in the brain. And then why that matters. So metabolism is the energy in the brain, the clearing, the plaques that causes later the Alzheimer's. So all that is affected. So lack of those hormones disrupts the pathways in the brain, not only how that brain works, but how it clears itself from all the plaques and garbage, and then therefore the risk of Alzheimer's. So I strongly feel that yes. And probably there's also a place for testosterone as well. We haven't spoken about testosterone at all, but many women who are on optimized HRT, hot flashes, everything is fine, but they're still complaining of, yes, libido, low libido, but still complaining of brain fog and brain not working like they were, the fatigue, the lack of confidence, lack of interest in things. And then once you start them on testosterone, many of them, they will say, my brain is actually working again. So I would be interested to know, what's the role of testosterone in the play of dementia and development of dementia? We just don't know. There's a lack of evidence in everything around this topic. But definitely estrogen, I think, plays a role, but maybe there's something more that we don't know about.
Absolutely. A question that I had from our conversation last week when we were talking about nutrition and getting the right amount of protein, I just wanted to ask a clarifying question, because it was 1 gram of protein for every pound of body weight, or 1.6 kilograms, right?
Yeah, so 1.6 grams per kilogram of ideal body weight.
Okay. So for example, I think it was with Robin, she wanted to release a few pounds. So if someone was wanting to make sure that they got the adequate amount of protein, but they also know that they are carrying more weight than they want to, would they, so if they say that their ideal body weight would be, let's say 150 pounds, that would be the maximum.
Yeah, so imagine what would be considered normal weight for that height.
Right.
Yeah, so just make it simple, not like what you would want, but what's kind of normal weight for that height, and that would make it easy to calculate, or at least, let's just get at least 30 grams of protein with each meal. Like, we can make it
easy.
simple. Yeah, so just get a lot of protein with each meal, and I will be very happy.
I made this gigantic salad and I was like, I'm weighing everything and I'm like, dang, I'm going to eat it though. It took me it took me like an hour, which is slowly, but I'm like,
Yeah.
okay, I'm working at it. But thank you for that. Dr. Dovile, thank you so much for taking so much time with us. And it's so valuable. There's not enough of you out there. So we are so grateful to have you to come on. Once again, anyone reach you if they have any questions, and mention your website once again. And I know you also have articles on Medium.
Yeah, I'm on the menopause support care providers group. My website, if you just share in the show notes, they can always drop me a message if they want to discuss lifestyle or anything else in more detail. I do the private sort of counseling about the lifestyle. I don't prescribe online, so that's one thing to know, but definitely open to do the education part. And I'm doing workshops and webinars for companies as well. Find me on Facebook and drop me a message, or Instagram or LinkedIn or Medium, anywhere.
Wonderful.
I'm everywhere.
Wonderful, wonderful. And we're so glad you are. Thank you so much. It's been a pleasure. And once again, stay tuned for more episodes of the Menowave Lounge as we interview other Menowave care providers like Dr. Dovile. Follow us on Facebook, on Instagram under the Menowave Lounge, Hot Flashes and Cool Conversations. And we're also anywhere you listen to podcasts like Spotify, Apple Podcasting, Amazon Podcasts. We are out there everywhere as well. Thank you so much. And until next time.
Thank you.
Until next time.
Thank you. Bye.
Thank you for joining us in the Menowave Lounge. If you'd like to connect with Marti, Robin, our guests, or any of our expert Menowave care providers for personalized advice and support, head on over to our website at menowave.org and fill out an assessment that will match you with a provider who knows just how to help. Remember, you don't have to face menopause alone. Our team is here to provide the guidance and care you deserve. So, take that step towards reclaiming your well-being and connect with a Menowave care provider today. Thank you again for tuning in, and we'll catch you on the next episode of the Menowave Lounge, Hot Flashes and Cool Conversations.